It's really a pleasure to be here and to talk to all of you and really hear from you, your thoughts of the reduced LAP HF2 overall data and the responder analyses that we've done and your experiences with implanting the device. So you all are well aware that in the reduced LAP HF1 trial, this was a small mechanistic proof of concept trial, 44 total patients, 1-to-1 randomized to sham control or the intratracheal shunt device. And what you can see here that it did meet its primary endpoint, which was 1 month exercise pulmonary capillary wedge pressure. So on the left at baseline in 1 month, almost superimposable in the control group. And in the shunt device group, you can see at 1 month in blue, a nice reduction in legs up, 20 watt and peak exercise pulmonary capillary wedge pressure. And so that led us to the reduced LAP HF2 trial. Just to remind you what the design was, this too was a multi-center 1-to-1 randomized sham-controlled blinded trial. This was much larger, 89 sites throughout the world, 626 total patients are randomized. And the important thing is that the patients underwent rigorous echocardiographic and invasive exercise hemodynamic screening. And we did the gold standard diagnostic test in HFpEF. All patients underwent exercise invasive hemodynamics, and they had to have an exercise pulmonary capillary wedge pressure of greater than 25 millimeters mercury. And then we tried to enrich the trial with patients expected to benefit most from shunt therapy, and I'll show you how we did that. And we, at the same time, excluded patients unlikely to benefit. So how did we do that? Again, we had the gold standard diagnostic criteria for HFpEF. And generally speaking, this was your typical HFpEF and also mildly reduced EF. And not only did the exercise pulmonary capillary wedge pressure have to be greater than or equal to 25, they had to have a gradient of at least 5 between the LA and RA pressures. Now, mainly the exclusion criteria I'm showing here are patients unlikely to benefit. So if they had a very low cardiac index, severe heart failure class 4, previous inotropes, previous low EF, if they had any complicating factor in the past 6 months as shown here. But then these were the ones that we really wanted to try to rule out patients who had RV dysfunction. So greater than mild RV dysfunction or enlargement, moderate or greater tricuspid regurgitation, and resting elevated RA pressure or elevated PVR. Now, what we didn't know, and as we'll show you, we didn't forecast that exercise would be important. We were basing these on resting criteria. And remember that we're shunting from the left atrium to the right heart. So if the right heart is already sick, these patients are not going to benefit. At least that's what we hypothesized. So these are the baseline characteristics of the 626 patients. Older, mean age 72, 60% female, multiple comorbidities. The majority, 93%, were HFpEF with an EF greater than or equal to 50%. You can see their health status was very poor. The KCCQ was 46. In the pharma trials of HFpEF, usually it's 70. For the KCCQ, the lower the score, the worse they are. So very, very poor health status. That combines symptoms and quality of life. And they had very reduced exercise capacity. 6-minute walk distance was only 300 meters and elevated NT-proBNP. Now, the median resting wedge pressure was 18, and 29% of the patients, about a third, had a resting wedge pressure that was less than 15. Now, all of them subsequently with exercise had a wedge pressure that went up to 25 or higher. But remember, this is very different than, for example, the V-Wave trial, Relieve HF, which does not include any invasive exercise. They only do resting hemodynamics. Now, unfortunately, the primary composite endpoint was totally neutral. This shows cumulative incidence of cardiovascular death, or CVA, stroke, and then this is the cumulative heart failure events. And you can see that the Finkelstein-Schoenfeld win ratio was exactly 1. So greater than 1 benefit, less than 1 harm, and it was exactly 1. And when you have a trial like this, as we have had many in HFpEF, either it's totally neutral across the board, or there's a responder group, which means there's also a non-responder and potentially do worse with the device. And so we looked at this further in pre-specified subgroup analyses, and the 3 that were significant, these patients highlighted in blue did worse. So men did worse with the device, RA volume index at the highest tertile, and pulmonary artery systolic pressure at 20 watts. So during exercise was at the highest tertile. These were the individuals that did worse. And of these, the strongest one was this one, the pulmonary artery systolic pressure. So let's look at these in further detail. So first, what about the gender differences? So women and men had similar rest and exercise pulmonary capillary wedge pressure and PVR, but women had less atrial fibrillation, diabetes, and coronary artery disease, also had less prior heart failure hospitalization, but had much worse KCCQ, much worse quality of life and symptoms. As expected, they had smaller cardiac chamber volumes and higher ejection fraction and better strain values of all 4 chambers. Now, the win ratio overall, which combines the mortality, stroke, recurrent heart failure hospitalizations, and KCCQ, was fairly similar between the two, but women definitely had less recurrent heart failure events, and this was statistically significant. The incidence rate ratio of recurrent heart failure events was 0.77 versus 2.19 in men, so something was going on here. So how do we connect the dots between the two things we found, gender or sex differences and RA volume index? Well, it turns out that women had smaller RA volumes, and of course, patients with smaller RA volumes were more often women. So that made sense. But the other thing that stood out was pacemakers. Men were more likely to have pacemakers slightly, and definitely those in this group that did worse with the big RA volumes had a pacemaker more commonly. And so really we zeroed in on the pacemaker, and we'll get back to that in a little bit. Now, importantly, after excluding patients with pacemakers, the sex differences went away. So we don't think it's women specific or men specific do worse, women do better. It's this pacemaker issue that seems to be confounding this association. Now, patients with pacemaker were quite different. They were a bit older, they were less obese, they had less diabetes, but they were much more often in AFib flutter, lower EF, moderate or greater TR, and had much bigger right atrial volumes. Right atrial pressure was also slightly higher. Now, what's important is that if you look at the pacemaker patients, they had a win ratio of 0.63. Remember, win ratio less than 1 is they did worse. So the pacemakers are, it may be that pacemakers are causing atrial dysynchrony that's causing issues, but we think more likely pacemakers are a sign of a sick right heart. And the sicker the right heart, the worse the patients do with the device. Now, let's look further at this PA systolic pressure 20 watts. Something about exercise PA pressure was important, so we analyzed this further. Now, we know that PA pressure is equal to the pulmonary vascular resistance times the cardiac output plus the wedge pressure. And when we have the device in, we think wedge pressure is going down, right-sided cardiac output is going up, but what about PVR during exercise? And so what we did was we looked at markers of pulmonary vascular disease in a very systematic fashion. We looked at all of these, and we looked at hemodynamic markers of RV dysfunction during rest, legs up, and during exercise, and also the TAPSE-PASP ratio. And we looked to see which one of these correlated best to the difference we're seeing here in time to first heart failure event, total events, and change in KCCQ. So in other words, which one of these variables was most predictive of a responder, if one way or the other? And we found that it was PVR at peak exercise that was most important. But before we go into that, let's just take a pause and ask ourselves, what is the normal peak exercise PVR? Now, there's not a lot of data on this, but there's a nice study. It was only 55 patients, but they were, middle-aged. A third were aged greater than 55, and they had similar resting hemodynamics, but older individuals, so those older than 55, had elevated PA pressure and wedge pressure and lower cardiac index during exercise. Now, this is totally healthy people. And the mean PVR was 1, standard deviation is 0.4. So if you use 2 standard deviations as above the mean as the upper limit of normal, that's 1.8 Woods units. So remember that 1.8 or greater is in a healthy people is abnormal, okay, for exercise PVR. Now, it just so happened that our highest tertile of PVR, exercise PVR, in the trial was 1.74. And when you look at that, we call this latent pulmonary vascular disease. So either the pulmonary vasculature doesn't vasodilate during exercise or vasoconstricts during exercise. If you have the latent PVD, your win ratio is less than 1. If you don't have the latent PVD, so 2/3 of the patients, then your win ratio is greater than 1. So besides lack of a pacemaker, so no pacemaker, and exercise PVR less than 1.74, those were the two groups that seemed to benefit with a win ratio that was higher. You can see that the heart failure incidence rate ratio differed and change in KCCQ differed between these two groups. Now, like I said, there's some patients that vasoconstrict during exercise and some that don't vasodilate. So you can see that some patients had a high resting PVR, but then that PVR went down with exercise and vice versa. So, it's not that all patients are the same, that they all vasoconstrict or they all vasodilate. Remember, the normal response is vasodilating with exercise. And this seems to be a key pathophysiologic marker. Now, the other interesting thing here is as you go up in exercise PVR, the pressure difference from rest to peak exercise, your wedge pressure actually does not, now this is rest before the device, this is at baseline before the device, your wedge pressure doesn't go up that much during exercise if your peak PVR is high. So what does this mean? The blood's getting trapped in the pulmonary vasculature and it's not raising the LA pressure. Now it raised it some, but it didn't raise it that much. And so you can tell that if in these patients with high exercise PVR, if your LA pressure doesn't go up that much with exercise, a shunt is not going to be able to decrease it that much. On the same hand, the RA pressure did go up quite a bit during exercise with the PVR at the higher level. So now what we see is that your resistance to the shunting is going to go up with exercise. And this is a key point of why we think these patients do worse with the device. And so this is kind of an interesting plot here. So across the board in the sham, no matter what the peak exercise PVR, because remember this is sham, they all increased by about 10 points. So this is very stable. This is why it's so important to do a placebo-controlled trial. They all increased by 10 points. But you can see that in the atrial shunt device arm, right around a PVR of less than 1.74, they did better in KCCQ. And then if you were above that, they did worse with the KCCQ. So a clear signal here, right around that threshold of normal. This is right around 1.8 to 2. And so this kind of summarizes, if we do an analysis about big increases, you can see that in the shunt arm, if you had no PVD, you were more likely to have these big increases. And in those who had latent PVD, so exercise PVR greater than 1.74, you were more likely in the sham to have a better outcome. And so this, again, is another way of showing the same thing with KCCQ. And so now, if we combine no latent pulmonary vascular disease, so their exercise PVR is less than 1.74, and they have no pacemaker, now we're really seeing a benefit with the win ratio, with heart failure event rate, and with KCCQ. And so it's really this group, which is about 50% of patients, that seems to do better. Another way of looking at it, this is called the net wins. So this is exercise PVR on the x-axis, and this is the net number of wins. The win ratio works by comparing patients in the control versus treatment one by one. And you can see you have a lot more net wins at an exercise PVR less than 1.74, and you have a lot less net wins if it's above that 1.74. And these are all patients that, all patients except those with pacemakers. So basically, this to us tells us that as far as we know right now, the responders are those without a pacemaker and an exercise PVR of less than 1.74. And so this is the group we'll be focusing on in the next trial called Responder HF. So, just to conclude here, so what we're thinking about as we think about precision medicine and HFpEF, most pharma trials really are just enrolling suspected HFpEF. They haven't done the gold standard testing. And so there may be patients who don't have HFpEF in these trials. Here in the reduced LAP HF2, we had definite HFpEF by the gold standard, and we also tried to exclude these people that we thought wouldn't benefit, but we had to go a bit further. And this is really excluding PVD during exercise pulmonary vascular disease and pacemakers, and this is a large potential responder group. We estimate that in the US alone, this is about 2 million patients with HFpEF. So take-home points, the reduced LAP HF2 pivotal trial was the largest device trial in HFpEF to date. Placement of the shunt device did not reduce the total rate of heart failure events or improve health status overall, but pre-specified subgroup analysis showed that women, smaller RA volume, and lower exercise PA pressure did better with the shunt. And gender differences and RA volume seem to be explained by pacemaker. And finally, if you exclude those with pacemakers and have exercise PVR that's within the normal range, that's about 50% of enrolled patients, they seem to respond favorably to the device. So be really interested to hear Ralph's comments and your comments as to what this means and ideas about how to identify these patients. Thank you very much.